I'm Lauren Stiles. I'm the president and founder of Dysautonomia International. And uh, I have some slides. We're going to go over slides. And then I want to mention to everybody, if you have questions anytime during the talk or at the end of the talk, you can type your questions into the Zoom chat. And Catherine will try to answer some of them as we're doing the slides. We'll take turns like answering questions, typing them in. But if anything we don't get to in the typed in questions, we'll try to do, we'll leave some time at the end for Q&A. But the way the Zoom format works, you have to type the questions in. So, okay, we'll kick it off. And just so everyone knows, we are recording this. So if you can't stay the whole time, we're going to go till about 7, maybe a little bit before that. We'll send out a recording of this to everybody who signed up for the webinar. Okay, get my slides shared. And we get it in. Continue to share. Does that look good? Catherine, can you see that?
Looks great.
Okay, awesome. Okay, great. So this is our webinar on Dysautonomia Advocacy Week. And so in the past, we've always done Dysautonomia Advocacy Day, but this year we're doing it as a week. So advocacy is one of the 5 major program areas of Dysautonomia International. I'm sure most of you know we fund research on POTS and other forms of dysautonomia. We do a lot of clinician education work, hosting courses to educate doctors. We're now funding fellowships to train doctors and other medical professionals too. We do public awareness. We launched Dysautonomia Awareness Month back in 2012, and we do awareness throughout the year. Our patient empowerment programs are all of our support groups and the resources we offer patients, meetups, all kinds of educational training and opportunities for patients to connect with each other. And then advocacy, which is what we're going to talk about today. So we focus our advocacy at the federal level in the US because we are still a small org. We only have a staff of 7. And we need dysautonomia advocacy at every level of government in every country. But realistically, where we can make the most impact with a small number of people on our team and the limited budget we have is at the federal government in the US because they're the largest funder of medical research in the world. So that's where we aim our advocacy approach. And everything we do is completely nonpartisan, not only because we're a nonprofit and that's the law, but also because dysautonomia affects people from all backgrounds, all political stripes, and we really need as many champions as possible for our patient community in the halls of Congress and federal agencies. So we are not partisan at all. We want everyone to be on Team Dysautonomia. We're also strategic and realistic about our advocacy, right? It's really easy to say, we demand $1 billion a year in POTS funding, but that's not going to happen. That's not real. So we focus our advocacy on things that we can actually get, or that we have a good chance of getting, and we build upon it. So we ask for a little bit this year, then we ask for a little more next year, and we kind of keep progressing the relationships that we build with people in Congress. We focus on the elected officials in Congress, in the House and the Senate, as well as federal agencies that have a touch point with health, like the NIH, the CDC, the FDA, Health and Human Services overall, the Social Security Administration. So it's a lot of different agencies. And we really, really emphasize the local impacts of dysautonomia with the elected officials. So wherever you live, if you live in the US, a small town in Iowa, we want the Iowa representatives in Congress to know this is impacting your family and other people in your community that have dysautonomia, and sort of make it a substantive thing for them locally rather than just this kind of big national problem they have to worry about. We learn from what other diseases have done that has worked. We spent a lot of time kind of mentoring with Parkinson's nonprofits and multiple sclerosis nonprofits that have been very successful in getting a lot of federal funding. And we also play the long game. We're not in this for a one-time win and then go home, right? Congress, they're constantly changing. There's constantly new people working there in the staff. There's constantly new elected officials, different people in different positions of powers on different committees. So we're there to build long-term relationships because the person who you meet in one of these congressional meetings who might be a young staffer. You might think, well, this person doesn't have any influence. They're a 25-year-old kid working in a senator's office, right? But that 25-year-old kid might be the chair of the director of the NIH 10 years from now. So everyone in DC kind of evolves in their roles. So we really think about trying to build long-term relationships. And then we also take the approach of building bridges and not burning them whenever possible, right? There are different styles of patient advocacy. Some orgs take a, burn down the bridges, pitchforks approach kind of advocacy, and that's fine for them. If that's working for their community, that's fine. But what we try to do is really find the positive, find the things we agree on, and that's not really popular in Congress, right? This current Congress and the past few years of federal politics has been just really divisive. But we can't let ourselves, we all might have those opinions in our personal politics. Everyone has an opinion. But in terms of our dysautonomia advocacy, we are viewing ourselves and we want our advocates to view themselves as people who are building connections and relationships and not pushing someone to the side and saying, well, those people aren't good enough to be part of this, right? So here's a photo of one of our prior advocacy days on the Hill. We started doing this, I want to say the first one was either 2013 or 2014. And we've gotten, a couple hundred people come every year. And it's a lot of fun. It's a lot of hard work. It's hot in DC most of the time. And as you know, for dysautonomia folks, that's not always fun. But we've been very successful. We actually got a lot of things done. They're not big, flashy, New York Times headlines kind of stuff, but a lot of very practical things that have had an effect on our ability to get research done and our ability to improve care for the patient community. And we don't just focus on POTS. I know sometimes people think that's all we do because you probably hear about that more often, because POTS is the most common disorder amongst the online dysautonomia community. So you just have more people talking about POTS and donating to POTS and volunteering for POTS. But we as an org think we have to understand all of the dysautonomias to be able to help our community. And if we study something in one disease, it probably benefits patients in the other diseases too. And then outside of official dysautonomias, we also care a whole lot about all the comorbidities our patients have, right? Ehlers-Danlos syndrome, mast cell activation, ME/CFS, long COVID, Chiari. There's just a million list of, if you're part of our patient community, you know these diagnoses, you've heard of them. And so even though our advocacy focus is on the dysautonomias, because nobody else is really advocating for us, we always try to work with other orgs and, making sure when we're talking to Congress, we help them understand that dysautonomia is connected to long COVID, dysautonomia is connected to Lyme, right? So there's a lot of different aspects to what we talk about in Congress. So, Katherine, do you want to tell us a little bit about these asks? I figured I should sort of have you pop in here and talk about what we're doing.
Absolutely, I'm happy to. So we have our three congressional priorities or asks for our advocacy initiatives this year. Lauren and I will go into more depth on all of these, but just as an overview from the beginning, our first is to increase research funding at the National Institutes of Health for both POTS and all other forms of dysautonomia. Our second is to add POTS and dysautonomia to the CDMRP, which is a DoD department that funds a lot of medical research, and we'll cover more on that later, as well as expanding access to care for dysautonomia patients within the military health system, which of over 10 million Americans use the military health system for their health care. The last is to expand access to care for our patient population through expanded telehealth services, which will be really helpful for accessing care out of state, as well as being able to have an appointment from a doctor from home if the patient is bedbound or has difficulty traveling.
Yeah. So maybe you'll do the first ask if you want to go over that one.
Absolutely. So, as I mentioned, our first ask is really increasing NIH investment in dysautonomia. So, In order to discuss why this is important, we should review what the NIH has funded to date. Here's a little excerpt from the RCDC on some conditions that the NIH has funded not very much research in. Postural orthostatic tachycardia syndrome, or POTS, is definitely one of them. This chart is by millions of dollars per year in research funding, which might seem like a big number, but in the grand scheme of NIH spending is actually very small. You can see only a few million has been funded in POTS research only in the last couple years.
Yeah, something I just wanted to add to this. So this RCDC is a report that NIH puts out every year on how much money they've spent in different disease areas. And so POTS wasn't being tracked for ever. And we fought for to get POTS tracked, and we asked for other dysautonomias too, but they only tracked POTS. We're still working on the other ask, but getting POTS tracked creates a little bit of accountability for the NIH, so the public can now see how little they're doing. And it seems like these are all kind of low numbers, right? So when you go into this, if you just Google like NIH categorical spending report, you'll find this big website that has all these numbers on it. And there's hundreds of diseases that have data reported, right? So if you sort this giant database of diseases by least funded to most funded, we are the one, two, three, four, five, six, seven. We're the eighth least funded condition in the whole NIH system. To be fair, they don't list things that get like less than $1 million a year. There's certain like super rare diseases or things that no one has applied for grant funding on. But you'll notice it's probably not a coincidence that the least funded diseases, DES is a sort of a drug that has caused a lot of birth defects and other problems. So it's like a I think it was a birth control drug. I'm not exactly sure, but it's like a women's health issue. Pelvic inflammatory disease is pretty much a women's health issue. Vulvodynia is sort of pain in the uh, sort of vaginal area, women's health issue. Vaginal cancer, women's health issue. Anthrax, not a women's health issue, just a scary issue that is not very common in the US, thankfully. Agent origin dioxin is also, not a sex-specific issue. Hyperbaric oxygen is, being used for a lot of things. And then POTS is mostly a women's health issue, right? Not entirely. So it's not surprising that most of the things at the bottom of this NIH list are girl problems. So I think even if you're a male patient or you're the parent or caregiver of a male patient, I think we have to understand that as we do our advocacy. Is part of the reason POTS is probably not super prioritized is because a lot of people who have it are young women. So that's part of our advocacy narrative is like, we need Congress to care about this. There are other diseases that are getting $100 million a year, $200 million a year, $600 million a year. And those are diseases that have lots of effective treatment options because NIH made that investment over time. So we've seen it go up a tiny bit, but it's still not where it needs to be. And then Catherine, I know you could continue if you want. I just wanted to interject on what that list looked like. Even getting POTS listed was really a fight to get it listed, and so we're glad they put it on. Now they just got to fund it.
Exactly. We were talking about how small some of those numbers were, and if you remember from the last slide, it was reported that there was $4 million in NIH research spending in 2023. But if you take a look at what was actually done, the research studies that they put in that category, you'll notice that the first two are not POTS at all. The first one is NOH, and the second one is OH, or orthostatic hypotension, which we're so thrilled they're doing research in. That is a form of dysautonomia, but it's definitely not POTS. So some of what they're saying that they're putting towards funding numbers isn't exactly what they're actually researching. So the tally is actually 3 million for 2023. So they're funding even less than they're reporting that they are.
Right. And you'll see that like three of these grants are one study. It just has like three different buckets because the money came from NHLBI is the cardiology branch, National Heart, Lung, and Blood Institute. NINDS is the neurology, National Institute of Neurologic Disorders and Stroke. and OD is Office of the Director. So it's actually cool that the Office of the Director is kind of like the director of the NIH decided that this was a really big deal priority thing. So they threw $1 million at it. But this is all just one study. So really, the NIH is funding three pot studies in this year. One, two, and three, right? As a small org, we're funding more than three pot studies a year. We don't have as much money as NIH, by the way, has a multi-billion dollar budget, right? And so it frustrates me that a relatively small org that's raising, $1 to $2 million a year is actually funding more research studies than the NIH is. Okay, so here's a little more on the spending breakdown, just for comparison, right? We're not suggesting that these other diagnoses should receive less funding. We're suggesting that, the funding for POTS as our example, because we don't really have good data on how much they're funding in the other autonomic disorders, but that there's no sort of equality in the amount of focus that diseases get, right? So Parkinson's is getting in the last year that we tracked $260 million in 1 year, which is a $99 million increase since 2016, right? POTS has been kind of flat at this $2 to $3 million level for forever. And MS has seen a $19 million increase since 2016. So it's not like they're only giving this much because there's not enough money in the budget. Well, if they found almost $100 million more for this one disease and $20 million more for this disease, why can't they find, $3 million more for POTS? So it's really a bigger picture problem than just not enough funding. It's also all these other diseases are getting more and more as NIH's budget has increased, which we think is good, right? Every dollar invested in NIH research in this country leads to more than a dollar in economic productivity. So NIH investment kind of pays for itself. And all of the NIH research is benefiting someone health-wise, right? Like it might not be us, but we're glad that Parkinson's is getting funding. We just also want to get funding. Okay, so here's just another way to look at those same numbers. So Parkinson's has roughly 1 million Americans have Parkinson's. So that's $260 per patient per year that the NIH is investing in Parkinson's research. MS, $116 million a year per patient. And there are many, many, many different FDA-approved drugs for MS because of that investment that NIH did. In Parkinson's, it's a little harder to treat because it's a neurodegenerative disorder, but there are lots and lots of different people studying Parkinson's and new research, all kinds of new research happening because of that investment. And POTS, we're getting less than $1 per patient invested in our disease area. So that just shows you sort of the disparity. And that's why we don't have any FDA-approved treatments for POTS, and we barely have enough research on the off-label treatments to prove that they work, which is why a lot of doctors don't want to prescribe medications for POTS or don't know what to prescribe beyond the very basics. So this research has a real impact in our clinical care as patients. So even though we don't have formal NIH data on the other diagnoses in terms of how much they're spending, we can kind of rough estimate by looking at how many journal articles are published on the other autonomic disorders. So syncope has a long history, and all the way back to the 1800s, people have been publishing on syncope, and a lot of research papers, over 1,000 papers published in 2022. And syncope is pretty common. There are different types of syncope, right? But syncope is fairly well understood by most doctors. I would, sure, if you have a lot of syncope, you probably think, no way, I can't get doctors to help me, right? But relative to other autonomic disorders, it probably has the most clinician awareness and recognition. Diabetic autonomic neuropathies, which impact 25% of all diabetics, there have been over 10,000 articles since the 40s. And there's a lot of research funding that goes into diabetic research. Parkinson's autonomic neuropathies has about 4,500 articles. Familial dysautonomia, which is a very rare form of a Jewish Ashkenazi Jewish genetic disorder that's extremely rare. There are fewer than probably fewer than 500 people in the world who have it. And a lot of the publishing on it happened in the 50s and 60s because it was actually one of the first autonomic neuropathy disorders described. It used to be called Riley-Day syndrome. So, relative to the number of people, there's only a handful of places that study it because there are so few patients that have it. It's actually hard to study. Um, POTS, we've had about 1,000 articles in total since the seminal Mayo Clinic paper in 1993 that first set out the diagnostic criteria for POTS. There were actually a few articles on POTS or POTS-like conditions prior to that, but they had not defined POTS until 1993. But we're kind of stuck in this like about 100 publications per year kind of thing, which is not not that much. Like look at syncope getting over 1,000 per year, right? So MSA is fairly rare. It's a neurodegenerative, very serious and unfortunately fatal type of dysautonomia that typically happens in older people. And there's been, just about the same numbers, roughly the same number of articles of POTS. And MSA is fatal. It affects about 65,000 Americans was the last estimate I read. So you certainly like, I don't want anyone to think we are comparing and saying like, well, this disease doesn't deserve more because there's fewer people. No, we actually want to see funding go up for all of these conditions. And when they do a study on Parkinson's autonomic neuropathy, it actually can benefit patients with all these other diseases. So it's pretty important. PAF is a pretty rare prime blanking primary autonomic failure. Why am I having a total? I'm having a POTS brain fog moment for you right now. So, anyways, autonomic failure is pretty rare. And AAG is autoimmune autonomic ganglionopathy is also pretty rare. Fewer than 1,000 patients in the U.S. And there's only maybe two or three autonomic labs that really specialize in it. So overall, it's like, there's some conditions that are getting a decent amount of articles and funding, but really a lot of it is really being neglected given the scope and the severity of dysautonomias. So here's our second ask. Catherine, do you want to sort of kick us off on this one a little bit?
Absolutely. So, as we mentioned briefly earlier, our second ask is to add POTS and all other forms of dysautonomia, if we can swing it, to the congressionally directed medical research programs, which we'll cover in a little more detail in a moment, as well as expand access to autonomic specialty care and dysautonomia care for all of the Americans who rely on the military health system, or the MIHS, which is, again, over 10 million people.
Yeah.
So I mentioned the CDMRP earlier and said that it's a DoD program, but it funds biomedical research, specifically congressionally identified health matters. So matters that Congress thinks is important enough that they need to put a little bit of money aside and tell the CDMRP, we're giving you this much money to look into this because it's really affecting our population, which is a wonderful way to make sure that research on something we want to see funded is funded. Last year, the CDMRP budget was about $650 million. And there are other conditions on there that are things we might be quite familiar with, things like long COVID and ME/CFS. And it's absolutely time to make sure POTS and other autonomic disorders get a little cut of that funding too.
Yeah. Um, this is I'll go through this. So
Sure.
the understanding, like you might think, well, I'm not in the military or the military health system. Why does this matter to me if these military folks get care? Obviously, like, we want to support the veterans and their families and active duty folks. But the military health system actually plays a pretty important role in training doctors who later become civilian doctors. So it benefits the whole of the US and maybe even broader than the US because sometimes people train in the US and then they go to other countries to set up their own autonomic clinics. So there's a very, very high rate of dysautonomia within the military health system because there's a lot of people in the military who get blast injuries or concussive injuries or physical injuries during even training operations that cause neurological effects. And Gulf War syndrome, really interestingly, one of the autonomic labs, or two of the autonomic labs, years ago, they published that Gulf War syndrome patients actually have a small fiber autonomic neuropathy. So if you read up on the symptoms of Gulf War syndrome, it sure sounds like a POTS orthostatic intolerance type of dysautonomia. So, and then all of the other forms of dysautonomia we just went over are also present in military families too, right? So there's really high autonomic burden. There's also things that like we don't think of as classic autonomic disorders, but that very much relate to autonomic dysfunction. So, for example, PTSD, which is extremely common in veterans. PTSD is largely a dysfunction of the sympathetic nervous system. And so, for people to be able to study that and understand that, they really do need to understand the autonomic nervous system. So, right now, the military health system serving 10 million people has one autonomic testing facility and one doctor, and he's on our board, Dr. Glenn Cook. And so, if you happen to be a military family and you tried to get in to see Dr. Cook, there's a good chance you got turned away, not because he doesn't care, but because he's one guy and he's got just endless families trying to see him, right? And he just can't. So they had to set up sort of a triage process where they sort of prioritize the active duty people first, because that's the military's, always their main focus is the military readiness. And then, people who haven't seen other autonomic specialists already. But it's very hard if you're one of those families and you're trying to get in to see the one guy you're allowed to see and you can't. It's very difficult to get referrals outside of the system, even though they're supposed to allow that. Sometimes it can be really hard to get that. So, Congress, unlike, your private healthcare system wherever you live, Congress doesn't directly control them. So Congress can't say to the local hospital in Indiana, like you have to start an autonomic clinic, right? But Congress can do that in the military health system because they directly control it and they fund it. So they can fix the fact that there are not enough autonomic labs and autonomic neurologists in the military health system. And we hope that doing that will actually, so think about all the patients who in the military health system who have dysautonomia that try to get in to see Dr. Cook who can't, they all eventually they end up seeing civilian doctors that are autonomic specialists. And then if we can get more autonomic docs in the military system, that could potentially free up the civilian doctors. The clinics are all, very long wait lists. I'm sure you've all experienced this. Trying to get in to see a specialist can sometimes be really challenging because of the wait lists, or sometimes they even close their wait lists because they just have too many patients. So this can help everyone by training more military docs. So I'm passing it over to Catherine again.
Absolutely. Our third ask for Advocacy Week this year is to increase access to care for dysautonomia patients and other patients as well through expanded telehealth services, specifically supporting things like the Connect for Health Act, which has bipartisan support, which is pretty exciting. This is a map we put together last year. It's not a very pretty map. You see a lot of states grayed out. Those are states who don't have any board certified autonomic disorders specialists. Now, I know many of us have wonderful doctors who are happy to treat our symptoms or do what they can for us, but it is very difficult to find a board certified autonomic disorder specialist. Those are doctors with additional training or expertise in autonomic disorders, and there's only 65 of those in the US. So
Wow.
you'll notice on this map, 23 states, as well as DC, don't have any specialist at all, and many states only have one or two.
Right. Even the states that have the largest number of board certified autonomic specialists, the biggest is Minnesota because of Mayo, and Texas because of UT Southwestern. So that's just one site in the entire state, right? And so that those 7 doctors at Mayo Clinic who do autonomics, they get referrals from all over the country because a lot of doctors say, "Oh, you have dysautonomia? Go to Mayo," right? So these 7 people cannot see the millions and millions of Americans that have dysautonomia. So we need to increase the numbers overall for sure. And
One of the
also,
reasons why, oh,
yeah,
I was going to say, you mentioned earlier that we're funding fellowships, and that's one of the reasons we're so excited about that is because we need more of these clinicians out there.
yeah, maybe just we should probably just explain what that is. So a lot of doctors, after they do get their MD, sometimes they'll do like a 1 year fellowship to get a real like specialty certification in a certain topic. And so we created autonomic disorders fellowships that we are now funding. The first one was announced at University of Toledo. Dr. Blair Grubb is going to lead that one. And we basically are paying the salary for to hire a young doctor to come train with him and work with him for the year and learn. And then in theory, that doctor, when they're done with their 1 year fellowship, they're already a doctor, then they're getting a year of hardcore specialty training. They should be able to lead their own autonomic program, either staying at the University of Toledo or moving away and starting a new one somewhere that there isn't one right now, which is kind of what we hope. Um, but anyways, expanding telehealth, a lot of us, after you have your initial workup and you're kind of you have a care plan that's sort of working, right? You don't always want to have to drive really far to see a specialist, or you don't want to keep going to get tilt testing all the time or anything. You just sort of need follow-up care to manage your meds and check in, maybe ask questions. And so telehealth would be really helpful, especially if you're so sick that like it's hard to drive, it's expensive. A lot of people have income limitations if they're chronically ill. So we think telehealth is a big important part of dysautonomia care. And so because so many of our patients don't have local experts, being able to talk to an expert in another state over telehealth would be really, really awesome. So the Connect for Health Act is specifically about Medicare beneficiaries. All of during the pandemic, the government made a lot of laws that allowed telehealth to be easier to do. Really, what prevents most doctors from doing it is the law. It's like there's all these regulations, right? So they made it easier to do it. And during the pandemic, a lot of us did get medical care over telehealth. But then that kind of phased out. And so the Connect for Health Act would make the pandemic related Medicare policies permanent. And a lot of times the private insurers kind of follow what Medicare does. So this has the potential to affect people who have private health insurance too. Um, and so that will be, we think, really, really helpful for not only just for dysautonomia patients, but for anybody with a complex illness that has a hard time finding a local specialist. So, okay, how can you help? How can you get involved in this, right? So you joined the webinar, you did the first important thing, you've learned about these asks. So Advocacy Week is virtual this year entirely. You can do it from the comfort of your couch in your PJs. Well, maybe for the congressional meeting, wear your PJs but put on a blazer. That's what Catherine and I do for these webinars. So, PJs on the bottom, blazer on the top. So, anyways, the congressional meetings are the 3rd and 4th of March. And so the way it works is that you'll register for this event. Registration is $10. If you can't afford the $10, we have scholarships available. The only reason we charge for it is because, well, first of all, it costs us a fortune to put this together. We actually have to hire a lobbyist to kind of have some influence with Congress more than just ourselves. And we have this app that we organize hundreds of patients to have hundreds of congressional meetings over a 2-day window. And that's pretty expensive. So we try to keep it affordable at $10. But if anyone really can't afford that, we understand. And so we have scholarships available for that. And so we invite people to register if you want to do the congressional meetings. And then based on the address that you register for, you give us the address where you live, and that will tell us who your members of Congress are. So we set up meetings. We try to set up a meeting with your two Senate members. So each state has two senators. So we try to set up meetings with them. And then we try to set up a meeting with your House member. Sometimes the actual members of Congress don't join these meetings, but their legislative staff that does health policy will join. And it can be tempting to think, oh, if the member of Congress isn't joining, it's not that important to them. Well, they're members of Congress. They're literally we're asked to participate in meetings like 500 times a day. So it's actually the staffers that do the work and know about these issues more. If you talk to a member of Congress about NIH funding, they're like, oh, yeah, that's important. Like they have no clue what the budget is. It's the staff that does all the work. Catherine will tell you, much like at DI. So, anyways, so meeting with the staffers is fine. It's not a diss. It's actually just talking directly to the person who's going to write the legislation we want. And even if they're really young, they can have a lot of influence. So we always try to be respectful. But so we'll have you guys register. There is a short training. It's very similar to this. Maybe people who've been part of the training, part of this can skip that, or we have to show you how to use the app on the training. But anyways, we'll show you how it works. It's very simple. So you're not lobbying the whole entire day. We're asking for a meeting. They're usually little half hour, 15-minute to half hour meetings is what Congress will give us. And they often will tell us like 3 days beforehand, right? So it's like kind of keep your day flexible, and then we'll tell you the exact time as soon as the congressional office confirms it. And so we'll hop on Zoom together and we'll have our meeting with the congressional office. You'll never be alone. There'll always be at least one other advocate from your state with you. And if there is nobody else from your state that signed up, well, there probably will be, but if there isn't, one of our staff members or our lobbyists will join you, so you won't ever feel like, oh my God, I don't know how to do this. I'm by myself, right? And it's not scary. Like they listen to constituents all day long. That's their jobs. And they will ask you questions, they will listen, But the challenging thing is if we have a meeting of a very populated state, like let's say Pennsylvania, and 100 advocates from Pennsylvania sign up, we can't have 100 people speaking during a 30-minute meeting, right? So what we will do in states where large numbers of people sign up, we'll assign like 4 or 5 people to be the speakers for that meeting. And then everyone else being there, it's still actually really important to be there because you're showing them that a large number of people in their state have this. So sort of having your voice heard is important, but also just being present. So the people who are speaking are going to say, we're all of these people have these same stories of misdiagnosis and difficulty accessing care, and we need better treatments. But most of the meetings you'll get to talk in, and there just might be some of the Senate meetings in the bigger states that get a little filled up.
Exactly. If you're from one of the more populated states, maybe Pennsylvania, maybe California, don't feel like you won't have an impact by registering. Obviously, letting people know how many individuals in a state care is really important, but
Mhm.
also your representatives can be your biggest champions as well. And
Yeah.
those usually have much smaller districts, and we want to make sure that your specific representative hears from us too.
Yes. And so this is the link if you want to, you could use your phone to kind of connect onto this QR code, or you could use this link. We'll also email, I think we just sent an email out today to everyone on our email list. So if you might check your email to register for Advocacy Day. And then in addition to the congressional meetings on the 3rd and 4th, and if you can only do the 3rd, you can tell us during the registration process, like I'm only available on one of these days. Um, and then we do have a short mandatory training. And after the congressional meetings on the 3rd and 4th, we're actually going to do on the 5th and 6th, we're going to have like an email advocacy campaign and a call your member of Congress campaign.
We might
Because
have something on the next slide for that.
yes. Okay. Yeah. And we'll have email templates and phone scripts and stuff like that to help people get through this. But Congress tracks how many constituents contacted them on an issue. They track the emails, they track the phone calls, they track the meeting requests. So, and it's okay if you do all three, right? Like that's fine. They're used to that. And it shows them like they actually track the numbers by topic and by issue because that tells them what's important in their home districts in their community. So turning out the numbers, getting like if you know other dysautonomia patients or families who can't make it to the Advocacy Day virtual meetings, still encourage them to do the email day, do the phone call day. We really, really need to turn out. We have a big patient community, right? And we need to turn it out. The other thing that helps us is when members of Congress have gotten, even if it's a phone call just to say, one of my loved ones has dysautonomia, and I really need my congressman to care about this and to learn about this. And please talk to those people at Dysautonomia International who have these advocacy asks that they're coming to you with. You don't have to even know the details. All you need to say is, dysautonomia, I'm your constituent, please care about this. And that tracks as person called us about this issue, right? And so then when our lobbyist does a follow-up a week from now and say, hey, I heard you met with some of our patient community members from your district. we will be more likely to get the meeting with that congressional member or that congressional office to do the follow-up work on like the detailed legislations if they know that a lot of people in their district have this and care about this. And that's worked for us in the past when we did like an email campaign and we had like 25,000 patients email in like one day. And then the next week, our lobbyist was like, "Oh, I can now call Senator so and so, who I know from some fundraiser. You know, the lobbyists, so we know they always know the congressman. I can call them because 680 people from their district called them on that one day." So, you know, it's kind of, we're a big community. We should flex our muscles, right? Um, so yeah, let's see. This is just another link, the bit.ly link that goes to the registration page. And if you guys have any questions, I think we should take questions now. I'll make the slides. I have to stop sharing to actually do the Q&A. See if do we have any questions?
I don't see any questions in the chat so far, but I'd love to hear them if you have them.
I see a couple questions in the chat. Yes. Okay. So yes, someone corrected me. DES wasn't birth control. It was a drug given to women when they were pregnant already. That is correct. Sorry, it was a little end of the day brain fog for me here. And yeah, it caused a lot of birth defects in people. So here's a good question. Are the number of patients to study ratio consistent with the NIH study priority and POTS diagnosis appears to have increased as a long COVID issue? Number of patients to study ratio. So what I had was the number of patients to NIH funding ratio and to the NIH. I'm trying to understand this question. But anyways, the data we have reflects how much dollars NIH is spending versus the number of patients that are reportedly having a condition, right? And so, yes, there are a lot of people who have developed long COVID POTS. So that ratio is probably even worse right now because and NIH has funded a little bit of long COVID POTS research, certainly not as much as we had advocated for. But yeah, those numbers will change as additional data comes out, probably. Somebody says, here's their question. I have AAG and my treatment plan follows myasthenia gravis treatment plans. However, it's difficult to get IVIG approved due to lack of evidence-based research for AAG. They would love to see more research on AAG, autoimmune dysautonomia's risks and benefits of IVIG. Heck yes, we totally agree. We have been pushing for this for years. There's so few doctors that study AAG. And another big important AAG research topic. So we know that half of AAG patients have high levels of the ganglionic acetylcholine receptor antibody. It's called GHCAR. GACHR, sorry. And the other half of AAG patients, we don't know what they have. There's no specific antibody or biomarker for them. So we think it's actually really important to study the seronegative patients to figure out what do they have? Because whatever immune biomarker is causing their seronegative AAG is probably present in other people who have dysautonomia too, just like the ganglionic antibody is. So that's a really important on our research agenda. But sometimes even when we have the money and we want to fund something, no one's taken us up on it. We're not getting researchers saying, yeah, we want to do this, you know. I will tell you, we are funding some ganglia pathology research in POTS and long COVID and fibromyalgia. We're really excited about it. It's not published yet, but stay tuned because we think that there's more pathology to be found there. Um, Somebody said, would you be able to share the PubMed list link, the specific articles we found on AAG, because they could use it to fight insurance. So I don't have the link off the top of my head, but the best thing to do is if you go to pubmed.gov, maybe Catherine can put that in the chat, pubmed.gov, and you search for autoimmune autonomic ganglionopathy or like AAG, you'll find all the articles. And some of them are open access where you can read the whole article for free, but others are just an abstract. So you have to have like journal access to read the article. And sometimes, if you know someone who's at a university, a lot of times university libraries will have a lot of the medical journals, or your local public library can help you get journal access too. Let's see, would the Connect Health Act support access to telehealth across state lines? Yes, 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 yes. That's a big important one. Someone said, can we just sign up for free for the email-based part? Yes, we have on the advocacy website, there's sort of a placeholder. We don't have the email portals. Like it'll be one of those, you ever do one of those like email your senator and there's like a template sample email and then you just type in your own little comments to it and your name and address and it'll send it to your members of Congress. We'll have that, but we didn't launch it yet because we don't want people sending it before the virtual advocacy days. So stay tuned to that advocacy page if you just want to do the email part. Yes, someone said, will you provide talking points and suggested email scripts? Yes. So for the virtual advocacy day, the congressional meetings, we do have a training where we're going to give people talking points and we'll do um, like a practice, like Catherine will pretend to be the congressional staffer and I'll be the rowdy, patient advocate. Give us our funding. And we kind of do some role playing, a little more serious than that. And then we provide bullet points. And because it's a Zoom meeting, you can have that just printed out in your hand or on your screen. And we'll even give you some materials you'll share with the congressional office, so they'll have the talking points too, so that they can take it with them after the meeting because they're going to have to brief their boss on what their meeting was about. And yes, when in the email, we'll have suggested, a sample email that you can sort of customize. And then for phone, we'll have like a suggested phone script. Is the congressional meeting hours day or evening? So Congress typically will do these virtual meetings, typically between 10 a.m. and 4 p.m. local time for their constituents. And it's usually a 15 to 30-minute meeting, but we won't know the exact time until a few days beforehand because that's just how Congress does their scheduling. Someone said I would be interested in the insurance acceptance data. Seems to be most of the holdup. Yes, we agree. We see it too. I don't know that that data is publicly accessible. Trying to get individual insurance companies to give us that data could be a project for the future, but they're not too keen on admitting that they're denying a bunch of stuff, right? So that would be pretty hard to get. Is there any prospective research on the connection between the different types of dysautonomia and mitochondrial diseases? Yes, we are actually funding a study right now at Case Western with Dr. Shamali leading it, looking at mitochondrial dysfunction in POTS. So mitochondrial disease and mitochondrial dysfunction kind of has some different meanings to different people. There's like classic like genetic mitochondrial genetic disorders that are defined conditions. And then there's a whole nother group of disorders where there's a problem with how the mitochondria works, but it isn't a classic like mitochondrial genetic disorder, right? And so he's looking at both in people with POTS. Um, Someone says the next question is how about international? Oh, by the way, that mitochondrial study, it's not published yet. We just funded it I want to say last fall, last summer, and it usually takes, probably like 2 or 3 years to get a research study done, even when everything goes as smoothly as possible. How about international pot studies? Yes, there's cool stuff going on in other countries. We're funding a plasmapheresis trial in Australia in POTS. We're funding the ganglia pathology study I mentioned in long COVID dysautonomia and POTS and fibromyalgia is happening in Europe. There's some European researchers who've contacted us that want to run some clinical trials. Yeah, there's a bunch going on. There's some POTS research happening in Canada at Dr. Raj's lab in Calgary. He's on our board and we've funded several of his studies. There are there's several different syncope studies happening in Canada right now and in the UK. Someone said, what about video evidence or props? So we generally don't use those in congressional meetings just because it's such a short amount of time that we have to meet with them. And we're trying to just really connect on a personal level, like their constituents having the time to talk to them. So we haven't really used any props. Catherine, do you have thoughts on that too?
I was going to say we do usually, and we'll go over this in training, of course, like to start the meeting with giving every advocate, you know, a maybe 30-second period of time to tell their story. Do
Yeah.
you have dysautonomia? How has it impacted your family? Why is this important to you? To engage the person that you're speaking with on why dysautonomia matters before you get into how they could help.
Yeah. And we would say, as patients, Catherine and I are both patients, and we've, had someone say, tell your story. What is dysautonomia? How does it affect you? And it's really hard to do that. A lot of us have long, complicated stories with a lot of misdiagnosed. Like I saw 40 doctors and they all thought I was nuts. And then someone figured out I had POTS, and then they figured out I had EDS, and then they figured out I had mast cell. And it's a lot of comorbidities for some of us. And I've tried 15 different medications, and it's a very long, complicated story on average. You can't tell that story in front of Congress. You have like an elevator, if you can do the elevator story, the 30 seconds. Because otherwise, if we had 10 people in a meeting and everyone spoke for 3 minutes on their story, we wouldn't get to the advocacy at all because we would just be doing our stories for the whole 30 minutes. So we really, really need to condense it and be okay with if someone else has a story very similar to you, just so, like my story is just like Jen's story, or my story is just like Michael's story, you know, and then jumping into the advocacy, because that's really why you're there, is to tell them the needs of the community. Um, Someone asked another question. Are you reaching out specifically to the military community to get their participation? Yes, and we would love your help if any of you have military members. Um, in your family, we would love your help. And they don't have to be the patient, right? It can be your Uncle Joe who lives in Nebraska. Like if he wants to advocate with you, that's awesome. We'll take it. Anyone who cares about this patient community, the doctors, nurses, school social workers, everyone's all on board. If you care about dysautonomia advocacy, we want you to attend this. So yeah, we do have a U.S. military support group for patients and caregivers and dependents that use the military health system in the U.S. We have a support group for that. So if anyone listening is a military family, we can you can find that group on our website, dysautonomiainternational.org/support. And that lists all of our support groups, including the military one. And I think the military families, it's hard for all of us to get care, but it's extra hard if you're on the military health insurance system because there is only one doctor. And so that really stinks. So, okay, so I think we got through all the questions, unless anybody else has another one that I missed. Did I miss any of them? Let's see. I would love everybody's help if you're still tuned in with us here, promoting this to other patients to get involved. I think a lot of times as patients, it's super frustrating living with this. It feels like no one cares, This is our chance to say like, hey, we're over here. There's a lot of us. We need your help. And other patient communities that have been able to mobilize themselves around, shared issues have done extraordinary things. Like the lupus community went from getting like $1 or $2 million a year in funding to $50 million a year in funding, and that happened over like a 10-year window, right? And now they get $50 to $70 million in funding every year. And so we think we can do that with the dysautonomia community, but we have to get people excited about this and feeling like their voice matters. So, anyways, well, thank you all so much. What's in the chat here? Oh, the PubMed link is in the chat. Thanks so much for tuning in, and we'll send out an email to everybody who attended to just make sure you all have uh, somebody says, I need a poster to take to Stanford or stand out there and tell everyone of the date. Okay, so to your Stanford friends, we have Stanford doctors on our board, so they know about this already. And I don't know if they're telling their patients about it, but definitely tell your docs, tell your advocate friends and family members, and hopefully we get somewhere with this. We get some progress. So, all right, have a good night. Thanks so much, Catherine. Appreciate it. You have any final closing thoughts for us?
Not real, other than everyone who's here, I really appreciate you listening, appreciate your passion for dysautonomia advocacy, and hope to hear your voice heard on the Hill soon.
Great. Take care. Good night.